So this week I've been having group tutoring sessions, and um honestly, I've had, let me tell you how many students I've had. Two, the whole week. Okay. And one of them came twice, and he's in my Monday class, and the other one wasn't in any of my classes. So technically, I had one student from all three of my classes that attended the group's um, review sessions. So I was a little disappointed, but it wasn't mandatory for you. So I can't be upset or anything, but I really would have liked to have seen more of you because we did some different things. And we went through case studies. So the one I did today was an hour, a little over an hour with one student, and it was a good time. But because we talked about some of his personal family stuff, I didn't record it. Okay. So what I'm doing is I'm offering tutoring sessions next week. So if you test on Monday, um, or Monday morning or Monday afternoon, I'll meet with you Sunday afternoon if you want to meet with me. And then those of you testing Tuesday afternoon or later, I can meet with you, well, Wednesday, not Tuesday, Wednesday or later. Then I can meet with you Tuesday. Okay. So let me know when you want to meet with me, if you want to do that before you actually take your HESI. Okay. So some recommendations for HESI would be the green NCLEX. It's HESI. It's a HESI comprehensive review for the RN NCLEX. It's chapter 6. And really there's quite a few pages, but not undoable. Okay, it's very possible. If you want something different to do other than looking at the same old PowerPoints, using the NCLEX book by HESI, might be a change up for you because it's formatted differently. So it just might be a little bit more refreshing to do that instead of the same old stuff you've been looking at. Okay. So we are in week 10, and you have your HESI a little bit of practice to do this week. If you didn't do your assignment from last week, go ahead and do it. I'll give you credit, complete credit if you will just do it. Okay. It's got a lot of questions on it, but it is excellent for preparing for the HESI. So take your time, look for the answers, look them up, make it a study time for you. Okay. And do the same thing with your practice. Okay. So did you hear me? If you didn't do your assignment, your HESI RN assignment, maternity assignment exam from your module, please do it this week. Look up the answers, do the best you can, and I won't deduct the 10% off if you didn't get it done. Okay, so do
I have a
those
question.
2 exams, get them done. Yes.
Are we allowed to go back and do them? I've already done mine, but for practice, can we go back and do them?
Yeah, you can do it as many times as you want, but I use the first score.
That's fine.
Okay. Yeah. Yeah. But if you want to, you can do that. You can also do a lot of NCLEX questions and read through the rationales. You can do that if you have 20 minutes, you don't know what to do with, which is, I know, rare. But if you have 20 minutes and you're just waiting on something, you can do NCLEX, do a group of 10 and read the rationales. Okay, so those are some suggestions as you're getting ready for the HESI. I have an antepartum PowerPoint I'm going to go over. Since antepartum was so long ago, we're going to go over that today. And then I have some whiteboards that I have to look at and clean up a little bit before I show them to you that we had fun with earlier in the week. So we'll do that. What else? Okay. All right. I was getting ready to send you an email and I ran out of time, but next week you're taking your HESI, right? That is your attendance. We have no class on Friday next week. Okay, no class next week. And then week 12, I'm going to have you meet with me between on Friday. I have 3 days that you can choose from. So week 12, you just have to check in with me. We don't have a typical class. There's nothing to talk about, right? So you'll meet with me. You can choose any of those days to show up. And it's going to be Wednesday, Thursday, and Friday in the afternoon from about 1 until I forget what I put down. I have it in one of my PowerPoints. And then Friday from 2 to 5. So all you need to do is sign on to Zoom and say, hello, Dr. Zeller. And I say, you're finished. And we can talk about whatever you want to talk about for your next class, maybe something you want to talk about this class, maybe some feedback, whatever. Okay, I might have a good question for you. Okay, so that's all we need to do for week 12. Okay, so HESI next week, don't show up to class. Go take your HESI. So so everybody in this class, I think you all are going to go to campus to take your HESI, correct? Nobody's using ProctorU in this class. Okay, so you go to campus to take your exam. Make sure you arrive at least a half hour before your scheduled exam. You'll use the Cuyahoga people. If you're signed up for the 5 o'clock exam, you have to take your own computer. But everybody else, just show up. You'll be using the computer on campus. You will not be on Zoom. You won't find me on Zoom when you're taking your exam, okay? Because whoever's with you on campus is your proctor, okay? And so make sure you get signed up. Is everybody signed up for their HESI? Yes? Yes? No? Anybody need help?
Hi, Professor. I have a problem signing into the HESI.
Okay. So did you see the exam?
Yes.
Okay. What problem did you have?
I'm taking other 2 classes and I went through the same process. I was able to register for that 2, but I couldn't register for this one.
Okay. Okay. Well, hang on after class and we'll see if we can get it fixed. Okay.
Okay.
I might have a
Thank you.
solution for him. I know we had that issue before, like me and another person from a different maternity class this term. We had to change our graduation date thing when you go in there.
Oh, your cohort. Yeah.
Yeah.
If you, when you started Fortis, if you've had to repeat a class or maybe you left Fortis and came back, you're in a different cohort. So look for like maybe October cohort. So just look at all the other cohorts in there,
I did that, but
different
it didn't
graduation
work.
dates, and you might find it. Okay, so I'll help you after class if you want help with that. Okay,
Okay. Thank you.
you're welcome. All right, does everybody understand now? Next week you do your HESI, no class. So actually, this is the last Friday at 5 that we're meeting. Okay, I want to thank you all for working so hard this quarter, and those of you who faithfully met with me and who asked for help. I hope you succeed in nursing because we certainly need nurses. Okay, so Miranda, are you talking? You're muted if you are.
Question, please. I'm sorry, I might have missed it. What are we doing for week 12 for
Week 12,
attendance?
yeah, Wednesday, Thursday, or Friday in the afternoon, I'll be on Zoom and I'll put I have the exact time on one of the PowerPoints today. Just jump on Zoom and see me and say hi and something like that. Okay.
Thank
All
you.
right. Has anybody ever heard of Nurse Blake? Yes, Jamie has. And Brandon has, that nurse that does funny stuff on YouTube. I mean, it's a riot. I can so much relate to some of the things he's saying. And if you want some of those YouTube videos, I'll give you a couple, and then you'll be able to see the rest of them. But they're kind of lighthearted nurse videos. There's one on nursing students, so it's really good. But anyway, I'll share those with you too today. Okay. All right. So let's just start on this one PowerPoint I have so we can discuss, go through it. And then that way we'll get some more information. Let's close that out. Okay. And I'll remind you, so this is the very last slide, but HESI next week counts as your attendance. Meeting with, so Wednesday the 29th, which is a week from this coming Wednesday, 1 to 5, I'll be on Zoom. Okay. You're not required to be there at 1. You're not required to stay until 5 o'clock. If you want to jump on at 5 till 5, I'm okay with that. Okay. If you can't meet me. If none of these times fits your schedule, if you're working, then I'll meet you some other time. Okay. So Thursday, 1 to 6, and then Friday from 2 to 5. Okay. So if you can jump on any of those times, if not, just let me know and I'll just meet you. Okay. Mandatory remediation for your HESI. So if you do your HESI and your conversion score is 900 above, you still need 1 hour of remediation. If they don't give you, if you look in your Evolve account where your HESI information is, and they don't give you a HESI packet for remediation, then you don't have to do it. Okay. And those are usually students who score like over 1,000 or 1,100 on the HESI. If you score between 850 and 899, you need to do 2 hours of remediation, which is in a packet. You'll get the remediation packet to spend 2 hours on. Okay. And so the lower your score, the more hours. Okay. So if you only make a 700, you've got 5 hours that you have to complete by the following Tuesday. So week 12, by Tuesday at midnight, you need to have that completed. You need to get your remediation all completed by Tuesday of week 12. Okay. Okay. So let's talk about some things about the antepartum period, I think, and some questions here. Okay. So when you're getting ready to take your HESI, you know, a mindset is really important. If you're so negative about your experience during this quarter, you got to get rid of that. Okay. You have to remind yourself that you really have learned a lot more than what you realize you have. If you feel like you don't know anything, that's not true. That's not true. You have learned a lot. Okay. You've done well enough on exams to show that you've learned something, right? And your quizzes, you all improved on your quiz scores. So you have learned a lot. Okay. So put that in your mind instead of being negative, and just don't feel rushed during the exam. Okay. Just use your mind, get some good sleep. Okay. Make sure you're eating right for a few days before the HESI. Okay. And certainly get some good sleep before your HESI. Cramming doesn't work. Okay. Cramming doesn't show really what you've learned. Cramming means that you don't know what you think you should know. Okay. Or what you think you should know is maybe not what you should know. Okay. So don't cram. Cramming is a last ditch effort. Don't do that. Okay. It's more important that you sleep an extra couple hours than to try to cram. Okay. And then I've already talked to you a little bit about the tools that you can use for studying. Okay. So let's talk a little bit about prenatal information. Okay. So if you have a client whose prenatal weight is 105 and she weighs 109 at 12-week visit, what is a good response to that client? What is most appropriate? The best choice here?
I don't see anything about her height, so how do we know her BMI?
We don't know her BMI. We don't really need to know her BMI in this for this. Okay.
Is it 3? The only one that sounds decent enough is 3, but they all kind of,
They're all kind of huh?
That's what I was thinking, because I'm like, I don't know what her BMI was. That's a normal amount of weight to gain in your first trimester.
It's a normal amount of weight to gain in the first trimester, which is what?
And I guess it would be 1.
1 to 4 pounds. 1 to 4 pounds. That you know, from week 1 when she's pregnant to when she knows she's pregnant to through week 12, normal amount that we like to see 1 to 4 pounds. Okay. So
Yeah,
she's
that's what I was saying.
okay
I
as
think
far
it's
as-
answer number 1.
Okay, so you think she should gain 20 more pounds during pregnancy? What if she gained 25?
It's not the end of the world. She's pretty small.
So it's recommended 25 to 35 pounds total during pregnancy, okay? So her BMI, she's underweight. I didn't tell you what her BMI was, but I just said she was underweight. So that means she is less than 18.5, okay? So asking her to consume extra complex carbohydrates. That's not enough information, is it? I think it would be best to just talk to her about what she's eating. So your weight gain for the first trimester is normal, okay? Since you're still underweight, let's talk about what you're eating. And that is the best answer, okay?
I would know that if I knew her BMI.
But it says her BMI was underweight. So you know it's less than 18.5. She's underweight.
Well, yeah,
You
that
don't
was one of the
really-
answer options, but it wasn't in the question, so I wasn't sure if it was adequate because, like, I was going based off the information in the question, not necessarily the answers.
I
If that makes
gotcha.
sense.
Okay. 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 What do you think?
4.
I wouldn't choose any of these. If she came in the clinic, I would do a urine HCG on her, and if that was positive, I'd do a beta quant.
Maybe 3. Because if she just missed her period, maybe it's too
Just
soon.
missed her period yesterday. I mean, you kind of need some more information. So that's why I say 4.
I'm between 2 and 4 because we technically can't order tests. We have to have the doctor. But that seems more reliable to see if she's pregnant.
I can order tests. It might be 3 though, because we usually recommend a week after a missed period, because sometimes periods are irregular.
Natasha, what do you think?
I'm the one that said 4 because she just missed her period yesterday. So you need more information.
That's a girl. That's what I want to hear. That's what I want to hear. We need more information, okay? Asking her about regularity of periods is very important, okay? Even though she's only 1 day late, ask her, well, are your periods normally regular, and go from there, okay? Athletes typically experience amenorrhea, okay? Amenorrhea. If they're really doing vigorous exercise and they're training for some kind of marathon or something, sometimes they won't have any periods, okay? Serum HCG is not a positive result. It's no more valid than a urine HCG because certain medications can give false positives. Okay. Yes, repeating the test at home in 1 week would be an option, but it's better to talk to her about her regularity of her periods. Okay. All right. Read this one. Whoops.
Are those the only 3 options?
Yep. This one's a little trickier. But
I'm thinking
I'm
about it.
just getting, pardon?
I'm thinking it's just 3 because I mean we don't know if one's true or not because we don't know if the patient's a carrier or not. We won't know until we do our new OB labs. And AFP doesn't test for sickle cell; it tests for neural tube defects. So I'm thinking it's just 3.
Okay, so AFP doesn't test for carrier. It doesn't have anything to do with the genetic. It's a for Down syndrome or neural tube. Yeah, you're right about that. So it's not number 2. So number 3 is correct. Remember the autosomal recessive inheritance, 25% chance that one of the children will carry the disease, 25% chance that one of the children won't be a carrier or won't have the disease, and then a 50% chance that the child will be a carrier. Okay, so that's not right. Okay, so I think probably the most important thing here for you to understand is that the autosomal recessive, there's a 1 1/4 chance that a child will actually have the disease. Okay. So we do the carrier screening anytime. It doesn't depend. We can do it before she gets pregnant. Okay. It doesn't have to, it's based on the mother's genes, not the baby's genes. And the alpha fetal protein test is based on baby's information. Okay. Is that clear? Does that make sense to you?
Professor Zeller, I do have one question for
Yes.
Hessie. Are we getting a next gen questions in this Hessie? Do you have any information?
Yes, you will have some next gen questions. Whether they're going to actually be scored, not all of them. Okay. So it's hard to explain, but yes, you're going to have a few of them.
So are we getting a partial credit on those, or it's just like if one is wrong, everything's wrong? Any
A
update
partial
on that?
credit.
Because usually next gen, that's what they are saying, right? We will get a partial credit, right?
I think so. I think so. So a lot of it, an example of a next gen question, one example is like an unfolding case study, like we do when I do one. You know,
Right.
I'll give you some information about a client and then they'll ask you some questions and you have to answer it. And then the next question is going to be more information. So it's the same case and asking you questions about it. So that's one next gen style. But yes,
Okay, thank you.
Because when you take the NCLEX, you're going to have next gen questions. So in the next classes that you're taking, you'll have opportunity to learn how to answer those questions.
Okay, perfect.
Okay. What do
The
you think
answer
this
to this
one is?
question, is it B?
Yes, anatomical ultrasound, exactly. Yeah, because it's routine at week 20 for all clients. Yeah. So she's 19, so she doesn't get a pap smear, right? And we're not talking about someone late in pregnancy who's having issues or that is high risk. And that would be your biophysical profile. And she's only 16 weeks visit. So we don't do glucose tolerance tests usually before 28 weeks. Okay, so that one was a little more difficult.
It's 3.
Yeah, you know, in this class, we haven't talked much about foods to avoid in pregnancy. And I don't really think your book talks about it too much either, but we definitely want her to know that everything has to be cooked. You know, listeria is a bacteria found sometimes in unprocessed or unpasteurized food or food that's not completely cooked. So, and that includes deli meat, because sometimes deli meat is not completely cooked. You know, if you get beef, if you have them slice off the beef, sometimes you still see that pink in the middle. So if she purchases that, we want her to put it in the microwave. And then some, certainly not sushi or any raw fish. Okay. And then canned tuna, we say 1 serving a week. Because tuna is a large fish and there's a lot of mercury in that. So we want to make sure she understands foods to avoid. Okay.
Two.
Why is 2 a good answer?
Because it doesn't negate what she's feeling and it allows you to gather more information because she probably didn't really feel that, but you don't want to make her feel bad.
Yeah, that's right. So you want to acknowledge what she's feeling and you want more information. Okay. Should she be feeling the baby at 10 weeks?
No,
When should she feel the baby?
it depends. If you've had multiple children, you feel usually earlier. I usually start asking around 17 weeks if they felt any fetal movement for multigravidas, but for or for first pregnancies, I just ask around 20-ish weeks. Sorry, I muted myself too early.
Okay, so your text says 16 weeks by 20 weeks. Okay, by 20 weeks, she should be feeling the baby move. Okay. Multigravidas, and Miranda's correct, multigravidas feel them earlier. I think I felt one of mine at 14 weeks. Okay, now you are assessing a client and you're determining where her fundus is. So if you assess it and you feel that fundus kind of right there where that belly button is, how many weeks gestation is she?
Twenty weeks?
All right, 20
Ooh,
weeks.
20.
Yeah. Hey, Blake, you want to turn your video on? 20 weeks is correct. So here, let me move this out of the way. There you go. 36 weeks. And then at around 40, if she's still pregnant, it tends to drop down. Okay. Where would 12 weeks be? Right down here, right? So usually we cannot palpate the fundus before 12 weeks because it's still behind the pubic bone.
Is it 3?
Yeah, and the reason I brought this up is because your book does talk about, and especially the Hesse Green book, it talks about ambivalent feelings at the beginning of the pregnancy, and then it goes on to talk about the father of the baby, what things that he might be feeling. So understanding that there is a little bit of ambivalence at the very beginning of the pregnancy, it's mixed emotions is another way of putting it. Okay, so you're not sure, do you really want this baby or not? That sort of thing. So it's not uncommon, but it's usually resolved by the time she starts feeling the baby, if not sooner. Okay.
I know for sure too, because that we would be concerned about growth restriction.
Number 4, I'd be concerned about possibly preterm labor.
Okay, Jamie, you're right about number 4. Number 2, it's a little high, or at the umbilicus, it's a little small, and intrauterine growth restriction is a very possibility, and you might see that if someone is smoking cigarettes, nicotine, or consuming nicotine somehow. Okay, at 17 weeks, if she's not feeling anything yet, we're not real aggressive about it, but some providers might want to go ahead and do an ultrasound at that time and just verify everything is okay. Hemorrhoidal pain. Why do women have worse hemorrhoid pain during pregnancy? If they have a hemorrhoid, they get pregnant. Why does it get worse towards the end of the pregnancy?
All the pressure that's down there.
There's
Yeah,
increased
there's a
blood
lot
flow
of
to the
blood.
pelvis.
Yeah.
That blood flow that's going down.
It's like a varicose vein, right? And there's a lot of blood in the pelvis and the pressure. So that hemorrhoid is going to, it can become external and very serious. Sometimes women have had to have hemorrhoid surgery during pregnancy.
Number 2.
Did everybody agree? Jamie's answering all the questions. Yes, that's correct. That fundus is pushing up against that stomach, and it's really bad when she lays down. What else might she experience when she lays down?
She can get lightheaded. She's putting pressure on her aorta. Yeah.
Her vena cava and her aorta. So the vena cava is just on the left side in front of the aorta. So that's why we have on the right side, I'm sorry, I'm turned around. And that's why we have our clients lay it on the left side. So when we compress those vessels, it reduces blood flow to mother and baby, right? So what would you see if she's in labor and she's lying on her back and she's experiencing that supine hypotension? What would you see? What fetal heart change would you see?
Likely
Would it
D
be
cells.
late
D
deceleration?
cells. Remember,
Late
if she's
cells.
lying on her back, she's compressing the vena cava and perhaps the aorta, reduces blood flow to her and her baby. So the baby's heart rate's going to drop. Okay. So we need to have her roll over on her side. As far as shortness of breath, what are some things we want her to do? What could we recommend to her? Don't make this any harder than what it
Sleeping
is.
in a like reclined position rather than all the way
Okay.
down.
Yeah,
So I
don't
would-
lay all the way down. Proper head up. Okay, proper head up. Yeah, yeah. Okay. I guess I didn't fill this out. So what might you see as far as lab work at 34 weeks gestation? Which one of these would you see in a client with no history of anything? First of all, you have to know what thrombocytopenia is, and you have to know what polycythemia is. So which one might you expect?
Well, polycythemia is just having more red blood cells than normal, which is kind of expected because you have an increased blood volume in pregnancy. Thrombocytopenia, that's not a good thing. That means that your thrombocytes are small and there's going to be a clotting issue.
Okay, so thrombocytopenia is low platelets. Polycythemia is extra red blood cells, and we don't normally have extra red blood cells during pregnancy. Hypothyroidism is not expected unless she has it before she's pregnant. So mild anemia is not unusual during pregnancy. Okay, so what would mild anemia be? What would you say? Do you know a hemoglobin value that would indicate some anemia in pregnancy?
Typically, if it's 10 and above, we only give them like ferrous sulfate. If it gets under 10, that's when we start looking into iron infusions.
Oops. So in pregnancy, we do not transfuse blood unless it's absolutely necessary. We usually don't even investigate. We might do iron studies to see if their iron levels are low, but we're not going to wait until they're 9 milligrams per deciliter. We're going to look if they drop to 10. We're going to look at iron, and then we're going to give extra iron. If we notice she's got a hemoglobin of 11 when she first gets pregnant, we might just go ahead and start her on some iron pills. Okay, but if it gets lower than 9, then we're considering we need to do something about it. Okay, so 9, so a normal hemoglobin 11 to 12. Okay, what's a low platelet level? Does anybody know?
Less than 150,000.
Good, yeah, less than 150. What if your client had a platelet level of 90? What would you think? Anybody know? What are 2 possible causes of thrombocytopenia, low platelets in pregnancy? Anybody remember?
Can't a lack of folic acid cause thrombocytopenia?
I don't think so. So low
I just
platelets.
Googled it. It can. A severe lack of folic acid in your blood can cause thrombocytopenia.
Okay. Severe, yes. For pregnancy, when we see low platelets, it's usually associated with preeclampsia.
Yeah, I was thinking about like I can never say it, decimated something that DIC.
DIC. So preeclampsia, severe preeclampsia, HELP syndrome, and then possibly DIC. Yeah. With DIC, we lose all clotting factors. Okay. So iron deficiency, that is just not getting enough iron. This is what you're going to see B12 deficiency is another anemia. And then some people just have chronic anemia. And then there's some other major thalassemias and stuff. You don't have to know that stuff.
Number 3.
Yeah. Number 3 is correct. And once again, acknowledging how she's feeling first. And because that's not only acknowledging is important, you're being empathetic, but you're giving her an opportunity to talk about it, almost like an open-ended question. Okay. And then you might guide her and suggest that she talk to someone on campus to set up maybe an alternate schedule.
6.
6.
That was the option 6. The same thing whenever they have to talk to the professor.
Yeah. But initially, you just want to acknowledge.
It's influenza. You can't have an MMR vaccine while you're pregnant.
Okay, mumps, rubella, and varicella are live vaccines. So none of those can be given during pregnancy. So when after the baby's delivered and before she goes home, we often will do the vaccines at that time. Because she can get them even if she's breastfeeding. Okay. So those were a little challenging for you, but it's not that if you didn't know the answer, sometimes you can really read the question, look at the answers, and figure out what the answer is. And so we talked about acknowledging feelings, looking at the ones you know aren't true, and choosing really the best answer for what your client needs. You know, when you're talking about weight and all of that stuff, you know, what are you eating? Okay, so as nurses, we're always asking questions. And you might come up with those kind of questions on a HESI or the NCLEX. And so learning how to answer a question when you don't quite understand some of the terms, then you figure out, well, which one is really acknowledging, which one's really addressing the issue at hand, okay? Okay, Blake, I was just reading yours. That's fine. All right, Mia, you're not on camera either. Where are you?
Stepped out to use the restroom.
Okay. All right. Let's go over this one. This is a PowerPoint that, whoops, let me go back to the top. And after we go through this, we'll take a break and then we'll do something fun, okay? Okay, do you remember Nagel's rule? Somebody besides Miranda tell me, besides Jamie and Miranda. Okay, Kinsey, what's Nagel's rule? It's right in front of you.
The mathematical, we can calculate from the missed period, last menstruation, all that fun stuff.
Okay, so it is determining the estimated date of confinement or the estimated due date. Okay, so first day of the last menstrual period, go back 3 months, add 7 days, and then a year. Okay. GTPAL. Okay. This is what we call the GP status. Remember, gravida is the number of times she's conceived, and then TPAL are the outcomes of those conceptions. So, shoot, I forgot to erase this. That's all right. Let me see this. You got that one. Okay, if you remember any of them, that's fine. So let's calculate your GTPAL. So how many times has she been pregnant? What's her G?
Five.
Can I answer?
Wait just a minute, Miranda.
5.
5.
5. So full-term babies.
1.
Preterm.
1.
Abortions.
2.
1.
1.
How many living children?
2.
Okay, good. Let's do another one. What's her G? Ashley, what's her G?
So is she currently pregnant right now with this question? Or is it just those that are on there?
That's what it said. Just go by what it says.
Oh, so G3.
Okay. Full term. Stephanie, full term, just one? Oh. Do we see a full term there?
0.
Yeah, 0.
None of these babies are over 37.
Yeah, 37 weeks is full term. Okay. Now, how many preterms? Passion, how many preterms?
3.
3.
How many abortions?
1. Okay.
It has to be less than 20 weeks to be an abortion. Okay, so how many living children does she have?
2.
Was that harder or is that okay?
Okay.
So just to review here about the cardiovascular system during pregnancy, we have a lot more plasma circulating, red blood cells circulating. The uterus is large, requires a lot of blood, maybe even up to 3 liters of blood circulating in the uterus at any one time. And the purpose for that is to provide adequate low blood flow to the placenta. Okay, so we see some physiological anemia or dilutional anemia. It's like a false positive. Okay, she still has plenty of red blood cells to take care of her own heart and her own systems, but we also need to provide that blood flow to the fetus. Reduced blood pressure in the extremities, or another way of saying that is decreased systemic vascular resistance. Widespread dilation of vessels in the arms and the legs, and in the torso, because we need that blood flow, like I said, to be in low pressure system in the uterus for the placenta. We've got coagulation factors that are more active or increased amounts, and then the fibrinolytic activity, in other words, the breakdown of the fibrin clot, less active. So she's got increased risk for blood clots. So you're going to see all kinds of things. Her hands are going to be more erythemic, nasal stuffiness, nosebleeds, lightheaded. Blood pressure doesn't normally change during pregnancy. It might be just a little lower during that first part of the pregnancy, but by the time that volume becomes increased as she progresses through a pregnancy, then the blood pressure usually returns to normal. Autosomal recessive, again, it's carrier. Do we have a client that has a gene? Is she carrying a gene that can cause a child to have a defective or a disorder? For autosomal recessive, the father has to have that gene as well. And so there's a 1 in 4 chance that each child, there's a 1 in 4 chance that every child will actually have the disease. Okay. And there's a 1 in 4 chance that they'll not be affected and not be a carrier. But half of the children that they have will be actual carriers like they are. Okay. So we're thinking of which particular diseases, which disorders are autosomal recessive.
Cystic fibrosis is one.
And what's the other one? The most common ones that we test for.
Sickle cell.
Yeah, that's right. Okay. All right. So remember when we do the AFP test, the maternal markers. So mothers, we can do like a quad screen or triple screen, and those are referring to markers. So there's different markers, right? And you don't have to know that. Okay, but you do need to know about the AFP. That's the one we talk about in this class. Okay, so if we have an if we draw the mother's blood, and we have to do this after 11 weeks, if we draw the blood and her blood has elevated levels of AFP, or if the levels of AFP in mother's blood are low, then the first thing we want to do is an ultrasound, okay? Just to see if there's any obvious signs of potential Down syndrome or neural tube defect. Okay, we do just a basic ultrasound. And then we might choose also then to do an amniocentesis. So we're going to draw amniotic fluid and we're going to test it for AFP. Okay. So these tests are not super sensitive and they're not diagnostic. Okay, we don't know for sure until that baby is born. It might be kind of obvious, but it's not really used as a diagnostic tool. Okay, so spina bifida or neural tube defects will have, the mother will have high AFP levels, or the amniotic fluid will have high AFP levels. With Down syndrome, and you can remember this by remembering low down, you're going to have low AFP levels. We can also do amniocentesis to determine lung maturity. And remember what the non-stressed, when would we do a non-stress test? Now, we don't normally do this before 30 weeks.
We see them a lot. Usually if it's like mildly high risk, start at 36, but I've seen them started as soon as 30, just depending on the situation.
So non-stress test, we can do them, you know, anytime, but for our clients like an adolescent who has intrauterine growth restriction, we're going to do some non-stress tests because we want to make sure that fetus is thriving. We want to make sure that fetus heart rate can adjust to movement. In other words, when the baby moves, the heart rate should go up. So we also do non-stress tests on a client that might show up and say, I haven't felt my baby move for a while. So we might do a BPP and a non-stress test. And this will tell us the well-being of the baby. Okay, so it doesn't, I used to do them at 32 weeks for sure for anybody who has high risk. Okay, just to get an idea how the baby is doing. Now the contraction stress test, we're just measuring how well the baby would tolerate labor. So with the non-stress test, we want a reactive, we want positive, and that's good. Okay, so reassuring, reactive, positive, that means the baby's heart is going up when it's moving. Okay, but the contraction stress test, we're looking at something else. We're looking for decelerations. Okay, so we want negative results. Okay, so if we cause a contraction, we don't want to see the heart rate drop. So we want a negative result. So if we say a contraction stress test is positive, that means that baby's having decelerations, okay? Or if it's reactive, it's bad, okay? All right. So we're calling these tests that we do during the third trimester as surveillance tools, okay? Ultrasounds, and then we also teach our clients about kick counts, fetal kick counts. In other words, be aware of how much your baby is moving, okay? There is no standard amount. ACOG or A1 doesn't say your baby needs to move this many times in an hour. No, it's just, is there a change? Okay, so my practice, I usually tell them, if you don't feel your baby moving all morning and maybe you've been busy, stop what you're doing and wait and count the times you're feeling your baby move. I like to hear that she felt the baby move 10 times in a couple hours. Okay, ideally 10 times in 1 hour, but I don't want her to panic. Okay, so if she's not sure, if she's having trouble counting, then especially if she's obese, then we need to do an NST or an ultrasound. Okay. Oh man, we sure did change directions. What is this? Stephanie, what is it? Did Stephanie go to the bathroom too? Okay. Anybody know what this is?
Is that dirt? Does she have pica?
Or pica, however you want to say it. It's dirt, yes. Yeah, it's not chocolate pudding. Okay. So what's so important about folic acid? Why is it so important? Kayla, why is it so important?
A lack of it could cause neural tube defects.
Yeah, yeah. So folic acid is a B vitamin and it's required for cellular growth. Okay. So if mother is pregnant and there's not enough folic acid in her system, that baby, when it's being formed, that neural tube doesn't completely close off and it leaves the nerves at the base of the spinal cord or at the top. It could be anywhere along the spinal cord. In this picture, this is a picture of a very low myelomeningocele. And there's exposed nerves here and they're damaged because they've been exposed throughout the pregnancy. Now, we are so good today, or we're so progressive today, that we actually do intrauterine surgery to close this up early during a pregnancy. But that is a very specialized tertiary care center, and not all centers are doing that. And it's not always that successful. But I have a granddaughter who has this, and what happens is they're born by C-section because they were pretty sure they were able to visualize the defect on the ultrasound. So right out, she was born
Would
via
this
C-section.
would this be painful for a baby? It looks like it would be painful. Anatomy that I'm
You
looking
know,
at.
I don't know. The nerves in there are not probably normal. They're probably damaged. And so whether they're sensory or motor, and they're probably both, but probably more of a hyperactive activity. I know that Zoe, who's my granddaughter, you know, after she was born, C-section, within 24 hours, she was at surgery to close this up. And since then, of course, she walks, she even runs today. So she had a very low myelomeningocele. But what happens is in her feet and her legs, they're very sensitive to touch and very almost like hyper reflexive activity. But yeah. Okay. Anyway, folic acid, which is found in citrus, leafy greens, beans. Okay. Adolescence, teen pregnancies, intrauterine growth restriction, very common, low birth weight babies. Remember, these women are still growing themselves. And so it's really important for us to watch them carefully and to monitor their weight gain. What are they eating? So it takes a lot of education. Okay. Also, any kind of maternal vascular disease can cause intrauterine growth restriction. So if we have someone with high cholesterol, if we have someone with cardiac disease, they also, because of the drugs that they have to take, they also might have a smaller baby. High blood pressure, chronic hypertension will also reduce the growth of a baby. We've talked about hyperemesis gravidarum during that first trimester, and sometimes women actually will have nausea throughout their whole pregnancy for some reason. The important thing with nausea and vomiting in hyperemesis gravidarum is we have to see what's going on with their electrolytes, and we have to replace them. Okay, they're severely dehydrated and they're depleted of potassium most of the time. So get an IV in them and check that potassium. So ideal BMI, 18.5 to 24.99. If you don't know your normal BMI, then, or you don't know low weight, normal weight, overweight, obesity, you need to know those. So somebody tell me, when is overweight? What's the range for overweight? Stephen, do you know?
I'm thinking 32, 35, but I might be off on that.
You are off.
35 to 40.
At 30 or higher?
— 25 to 30.
So ideal is 18.5 to 24.99. Overweight is 25 to 29.99. Obese is 30 to 39.99. What do we call 40?
Morbid obesity.
Morbid obesity. Okay. Nutrition. So this is just about some terms: pyrosis, heartburn. Complex carbohydrates are potatoes, pasta, rice, and beans. On your exam, one of your exams, I think it was the second one, there was a question about what a client should, with the majority of the calories come from which food types, or not food types. Was it fats, carbohydrates, proteins? And the answer, according to your text, is that 40% of the calories need to come from carbohydrates, 40% needs to come from fat, and the rest comes from protein and whatever else there is. Okay. We always think of increase your protein, and that's not true. She needs carbohydrates and fats. Okay. So complex carbohydrates, potatoes, pasta, rice, beans. So nicotine use, we've talked about. Low birth weight. Secondhand smoke, if she is
Professor, can
smoking.
we take a break real quick? I have to use the restroom.
Oh, yeah, we can. Yes. Go ahead. So let's break until 6:20. Okay, or 6:25. That'll give you more than 10 minutes. Okay, everybody. So this is what you call, can everybody see the whiteboard? Can you see the whiteboard?
No, I got a weird message about an error with the whiteboard, and that was as far as I saw.
I can see it.
Okay, so sometimes for some reason, an error. Miranda, are you on a Zoom app? Or are
Yeah,
you
I'm
on the
using
web?
the app.
Okay, that might be why. If you're using the web based Zoom, you might be able to see it. I don't know why sometimes that happens or not. Can everybody else see it?
I can see it.
So are you using the Zoom app?
No, I'm just on like the computer.
I'm on my
Okay.
computer, but I have the actual Zoom program downloaded. That's what I'm using.
Yeah, I know. That's what I use too, Miranda.
I
So
feel
you
like
see
I'm seeing
Jamie, huh?
I was trying to say, I feel like I'm seeing half the whiteboard. Like I see the brain, the lungs, the liver, kidneys, and then there's that little graph, but that's about it.
Okay.
Hold on, I'm gonna try to rejoin on my actual browser and see if that helps.
Yeah. Okay. So I have these sticky notes. And I have preeclampsia in my client here. See it? So all the way to the left, preeclampsia, and then there's a placenta. Okay. So when preeclampsia occurs, you know, it affects the other organs. So it causes reduced blood flow to the brain, the lungs, the liver, and the kidneys. Everybody see that? Do you see it, Stephen?
Yes.
Okay. So if you notice that Brandon has his cursor there, and now Michaela does. So you should be able to move stuff around on this screen, okay? So what I want you to do, any and all of you, you notice that we're infusing magnesium sulfate up here. Okay, right here. And if our magnesium sulfate is non-therapeutic or subtherapeutic, in other words, it's not working for our client, what are some things we would see? Now, don't move things around yet. But whoever's doing it is doing a good job, okay? So somebody move what you would see if magnesium level is subtherapeutic. Take one of those, okay, 148/80. What else might you see if the magnesium level is not working? It's not effective. She's still having signs of preeclampsia. Okay, proteinuria. And somebody else did preeclampsia. Let me move that down. Okay, good. Yeah. All right. So if it's therapeutic, move that around. Or if it's toxic. So everybody just jump in there and move stuff around. Jamie's doing it. Let's see, we got an extra one here, slurred speech. Okay. What's clonus? Do we see shortness of breath in toxic levels? If you see something that you think is wrong, move it to where it should be. Because there's a couple things on here that aren't right.
It's not letting me move anything.
Oh, I don't understand what's going on. What do you want to move, Miranda?
Well, clonus isn't that indicative of seizures? If it's subtherapeutic, they're going to be having seizures. The whole point of magnesium sulfate is to decrease the CNS activity and stop seizures.
Right, exactly. Yeah. So somebody did choose the eclampsia, which is, so clonus should be over there too. Exactly. What else? Anything? Is everything all right now? What would the urine output be if it was subtherapeutic? What would the urine output be if it was subtherapeutic? Passion, do you know? Subtherapeutic.
Would that be? I can't really see all of this because it's too small. My vision doesn't look like that.
If you double click it, it makes it bigger.
There you go. So if it's subtherapeutic, would you expect urine output to be normal?
Oh no. So normal was what, like 30 mLs an hour?
Yeah, yeah. And there's no sticky note for that.
Oh.
Yeah. Yeah. So 40 mLs an hour means it's therapeutic. Okay. It's therapeutic. Okay. And then, okay, is everybody satisfied? Yeah, so a normal deep tendon reflex is 2+. Less than that, you might see more in a toxic dose or a high dose. Okay, a deep tendon reflex of 3+ or 4+, or a clonus would be subtherapeutic. Okay. Okay, muscle weakness would be toxic levels. Okay, so everything is depressed. When the levels of magnesium are toxic, it depresses everything. It's almost like stroke activity or partial coma, because level of consciousness would be, you know, very lethargic. Okay, difficult to wake up. Okay, so lethargy would be another one. So that would be here. Okay. All right, so a normal blood pressure, this might be therapeutic too. Even though the top number is a little high, if she started out at 160 over 100, this would be considered therapeutic, okay? But actually 148 is a little high. If you had a client with preeclampsia and they were therapeutic, and yet their blood pressure was still high, so let's say 150 over 88. So it still might be considered therapeutic, but what would we do about that? What would you want to do? What would you do for your client? Everything else is fine, but our blood pressure is still too high. What'd you
Wouldn't
do?
we give them some kind of like blood pressure medication, probably labetalol?
Labetalol. Did I spell that right? Yeah, and we can also use, doggone it. What else? Or is it hydrolysine? I never remember how to spell that word. Okay.
Forgive me if I'm wrong, but doesn't preeclampsia cause shortness of breath? Shouldn't that be in the subtherapeutic?
All right. Yes, ma'am. Subtherapeutic. And why is she short of breath, Miranda? Why do we see that in subtherapeutic? What's causing shortness of breath?
Give me a second. I got to think about it. I'm sorry. I'm tired.
All right. Pulmonary edema.
That's the word for it. I was like, it's pulmonary something, but I didn't want to say the wrong word.
It's okay to be wrong every once in a while. Okay, pulmonary edema, yes. So we're going to see pulmonary edema actually before we see edema in the extremities. And you know that peripheral edema, facial edema, edema of the hands are really late signs. and you don't always see it. Okay, it's not part of the diagnostics for preeclampsia. Okay, so let me ask you this.
I also noticed something else that should be in subtherapeutic visual changes. That's something we see with preeclampsia as well.
So we do, but we can also see them in toxicity. Okay, blurred vision. So that would be another one. Yeah. So we'll put that up there. Might be seen in toxic levels too. Okay. Yep. And a heart rate of 50 is low, but if her normal heart rate is 70 and she's getting magnesium, it might be 50. What kind of a blood pressure would you see if she's toxic? Would we see this?
Low blood pressure.
Yeah, it should be hypotensive.
Yeah, so if she started out here and we treated her and it dropped to 90/60, that would be more over here. But you know, that's individualized, so there's no set number, okay? 90/60, I would be turning her on her side and I would be giving her fluid. We don't want to overload her with fluid. That's kind of low for therapeutic if she started out here. Okay,
I do
so
have a
it's
question.
Huh?
So I see that you have it listed like if her blood pressure was elevated, you guys might give her labetalol, but if her heart rate was 50, that's a beta blocker, which causes worsening bradycardia. So I wouldn't want to give it if it was 50.
right, that's true. We might reconsider. What would you want to give her then, Miranda?
I think hydralazine's an okay one to give.
Okay. What else could you give her? You know?
Fluids.
Yeah, I was gonna
Fluids,
say
definitely.
bolus. Oh, are you talking blood pressure medications or for hypotension?
Yeah.
So blood pressure medications, I know the biggest one that we give is labetalol. There's also hydralazine, but we don't usually use that unless it's like a hypertensive crisis. I'm trying to think of some of the other medications. I know that that's not coming to me right now. I'm sorry.
So nifedipine is another one. Procardia is another one we could give. And that's oral. It's a calcium channel blocker. So that would work. Okay, good. So let's say, and by the way, that medication was referring to the high blood pressure and the therapeutic, not the, I just had it pulled out here, Miranda. It's referring to 150/88, not 90/60. But
Okay, well,
good
it was
call.
just kind of in a toxic section. And I was like, well,
Yeah.
if it's toxic, I don't want to necessarily give her that with a bradycardic heart rate.
Yeah, no. If she's toxic, her blood pressure is not going to be high. Okay, let's say she delivered her baby. What would be, let me make this a little bit bigger. What would be signs of resolution of preeclampsia? How do we know that everything worked? It's 24 hours later and we're stopping her magnesium. What are some clinical signs that it's being resolved?
Number one, her blood pressure is going to start to stabilize on its own.
Okay, normal blood pressure for her. Okay, what else? Anybody else? No?
Increased urine output.
Urine output.
Okay, diuresis, excessive, maybe 3 liters a day. That's a
And
lot. What else?
diaphoresis.
diaphoresis. So we're getting rid of, she's getting rid of all her extra fluid. Remember, every woman that goes through labor and delivery, they have a lot of fluid on board, right? When that placenta is released, what happens to all the blood, extra blood and plasma that's in the mother's circulation? What happens to all the blood and the plasma that's around the uterus that is shrinking? It's shifting back to her regular circulation. So she has to get rid of all that fluid. So she is going to be diaphoresing and diuresing. But it was someone with preeclampsia, it's excessive. Okay. So we know it's resolving. Okay. Good. I don't know if I finished this one or not. I'm just now working on these because we just got access to. No, I'm not done this one. Let's look at this one. I'll let you look at this one for a little while, okay? Sabina, you're moving my chart around. Okay, so we have a client that's 24 years old. She comes into the clinic. I think I'm pregnant. I missed my period last month, and the home pregnancy test was positive. Here are her vital signs and her weight. Family history, and then obstetric history. Okay. What's her, let's start with her GTPAL. What is it? So it tells you down here on the left. Can you see that? Yeah. So what's her GTPAL? Two previous spontaneous abortions, one preterm delivery, two full-term delivery. And she thinks she's pregnant now. So we're just going to assume she's pregnant. So what's her G?
6.
5.
Well, if we say she's pregnant now, it would be 6, wouldn't it?
6. It's really
Yeah, 6. Okay. All right. So how many full-term babies has she had?
2.
2. How many preterm babies?
1.
That's kind of easy. And then how many abortions?
2.
How many children that are living?
3.
3.
Okay. All right. So her last menstrual period was January 28th. What's her estimated due date? January 28th. December, November, October.
November. Seventh. 2023.
4, 11, 7,
It's supposed
24.
to be 10, not 11.
Is it 23 or 24?
24.
23.
No, it'll
23.
be 23. It'll be 23rd.
Yeah.
But it'll be October. So October's
Wouldn't it be the 4th because you're like 7 days?
No, no, it makes sense.
You
Yeah.
have to add the 7 days and
yes.
7 day, yeah, it
Yes,
would be
yeah,
the
got
4.
it.
Well, it probably wouldn't even be the 4th because you have January
the 4th.
29th and 30th and 30th.
31st.
Yeah,
Yes, that's the
that's it. Okay, good. All right. So is she a multi-gravida down here at the bottom? Is she a multi? Para? What is she?
Yes, she's very much multi.
Multi what?
Multi-gravida and technically multi-para as well.
Yeah, right. She's both. Good. Okay. So are we concerned about hypothyroidism as a history? What effect does hypothyroidism have on pregnancy? Do you know?
Doesn't it make it harder to get pregnant because you have irregular menstrual cycles with hyper
Okay.
and hypo,
Right, yeah. You're
where
right.
the hormones are not working, so it makes
Right.
it a
So
harder situation for the person to get pregnant.
right. So if she gets pregnant with low thyroid, thyroid is one of those hormones that help with metabolism. So sometimes we see fetus with cognitive disability. Okay, cognitive effects on the fetus. Okay, so neuro problems. All right. So we need to, if she has a history, we definitely going to do a TSH on her initially, and I don't have that up here, but we're going to do a TSH to see where she is. We might have to increase her thyroid hormone. And so you can see the huge advantage of preconception counseling. So if you have someone who wants to get pregnant, we need to see where her thyroid is to make sure it's high enough, to get pregnant, and so that her baby will have the best advantage. Okay, so here's the blood work that we did on her. So we did a CBC, AFP, a urine drug screen. We did blood type. We did a cystic fibrosis carrier screening, and it was positive. We checked her thyroid stimulating hormone, and it was 8, and that's normal. Okay. We did a ferritin, and it was low. And we did the RPR, which is the syphilis, and it was negative. So that's good. So what do you think about her CBC?
She needs to be on some supplements at the very least.
Yeah, so she has anemia. Her hemoglobin is only 9.6. Okay. And we can determine what type of anemia. One way we can determine is by the MCV. If the MCV is below 80, it's usually an iron deficiency. Okay. You don't have to know that. Her platelets are 100,000. Are we okay with that?
That's low.
It's low. Yeah. So we don't know what that's about. We might investigate. Okay. And we're really not going to do anything else about that unless it drops down real low. Okay. Her AFP is low. What do we need to do about a low AFP?
Usually that's a indication that you need to screen further for Down syndrome, depending if her HCG is elevated as well.
Yeah. So the risk for Down syndrome goes up after the age of 35. Okay. So this is an indication. So what would be a good thing to do at this point? It depends how far along she is.
That's what I was going to ask. How far along is she? Because if she's like around 12-ish weeks, we can do an NT scan. If not, it might need to be a little more invasive.
Okay, so we need to wait a little bit. We can do an ultrasound. Okay, we can do an ultrasound for that. We might, if she's 15 weeks, then we can do an amniocentesis. But even then, sometimes providers choose not to. It's invasive. It carries risk, and the client might not want an amniocentesis. Okay. And her urine drug screen has THC. What's that? Y'all know what that is?
Marijuana.
Cannabis, yeah. So she's exposed or she's using it. Okay. And what about her blood type? Are we concerned? Let's see. Gopal, are you concerned about her blood type?
Maybe.
Maybe. Okay. She's O negative.
I want to
Stephanie,
say
what?
yes. Isn't her blood not compatible with basically any other kind of blood?
Wouldn't that be
Wow.
the RH?
Who said that?
Me,
Who's
Jamie.
me?
Jamie.
Jamie, you are right. O blood is not compatible with anything but O blood. Plus, she has no D antigen. She's Rh negative. Wow. So there's two issues here for blood incompatibility. So we need to, you know what we need to do with her? She's had previous pregnancies. So what do we want to ask her?
Do all of your children have the same father?
That's interesting. Okay.
The reason I say that is because if we're looking at the Rh negative and she hasn't had issues with other pregnancies, the chances are that her child's father is also an Rh negative carrier. If they have the same father, typically that's less of a chance of alloimmunization. But if they have different fathers, then that's when we kind of have to look further into it. I only know this because I have alloimmunization from a pregnancy, and I had to see a specialist for this.
Okay. So we also need to ask her if she received RhoGAM during her last pregnancy. Okay. We need to ask her that and ask her if she ever has been sensitized or if she got RhoGAM in all of her pregnancies. If we know about RhoGAM and she's never been sensitized, then we know that this pregnancy will probably be just fine. If she doesn't remember, then we need to do frequent ultrasounds on this baby. Miranda, do you happen
Yeah,
to
I
know?
was following the same logic. Like essentially, if she's been finding other pregnancies and all the kids have the same dad, then she's fine. That's where I was going with it.
Okay, yeah. So let's say we're not sure about her status. Miranda, do you know what test we would use to see if the baby is developing a reaction during the pregnancy?
There's a titer. I'm trying to think of the name of it. Hold on. I used to have this done like once a month. How did I? Hold on. Is it a Coombs titer?
Yeah, we can do a Coombs test, yes. But we can also do an ultrasound and we can measure the middle cerebral artery velocity, it's called. So if a fetus is developing hemolysis and anemia, the velocity of the blood flowing through the baby's brain is increased. Okay, that's kind of beyond where we are here. Okay.
No, I learned something
All right.
today. That's fascinating.
Yeah, it is. So risk for neural tube, is she at a risk for neural tube defects?
Not necessarily here. AFP isn't high, which is what you see in neural tube defect
So she's,
screening.
yeah, so it's the Down syndrome, yeah. So we might want to do an amniocentesis, okay? Maternal serum marker, that's what it's called, okay? Is she at risk for a preterm birth?
I feel like THC is linked to preterm birth, but I'm not 100% because I haven't really looked into it that much. So possibly.
I've not heard that. Okay, hey, Mia, what do you think? Is she a risk for preterm birth? What do you think? Look at her history.
I would say yes, based off of her history.
Yeah, because she's had one before. Yes,
Yeah.
yes. Okay.
And she had 2 previous spontaneous abortions.
And we don't know what caused those. Okay. It might have
Mhm.
been her anemia, right? It might have been her low thyroid. We don't know. Okay, good. Is she at risk for preeclampsia?
Yes.
Why?
Looks like she has hypertension prior to pregnancy, which is a risk factor number 1, and her BMI is over 30, so she's obese, risk factor number 2.
Well, her blood pressure isn't high, really too high. It's 130 over 80.
They told me
But she
mine
does
was
have
like,
she does
yeah.
have a family history, so yeah. And definitely she's overweight. And not only that, she has a family history of preeclampsia. Okay. All right. That was fun. Was that fun? Even if you feel like you couldn't answer any of those questions, you probably learned something, didn't you? Did you pick up on some things? So as nurses, when I asked you a question about the preeclampsia, you have to go back and look at her history. Okay, so look at her history. So if you're reading a question, make sure you go back to the question. Does it say anything about a history? Okay, especially if it's a next gen question. It gives you a client history and then asks you a question and goes down. Should you be expecting preeclampsia? Well, you have to remember what was in the history. Okay. All right. What article are you sharing with Miranda?
Curious where I had read that before, and I remember doing a research project on the marijuana and the preterm birth. I'm like, okay, I know I'm not crazy, so I started doing some research, and there's several links on the National Institutes of Health that actually link it to preterm birth, stillbirth, and intrauterine.
What's that? What's that?
That's just one of the
THC?
links if anyone's curious. What's that? Mm-hmm.
Okay. Good. Yes, I know that they're wondering. They also are finding, you can't take one research study and make a clinical decision. The best way to make a clinical decision is to look at groups of studies. So if you read one article, you can't say this is what's going on, okay, if it's just one study. But the National Institutes of Health certainly is a great website to see what's going on out there. And then, of course, there's other websites too, but yeah, that's good. Yeah, THC, we're not sure. We also think that if a mother is exposed to it, or if she's smoking it, or whatever, however she's consuming it, that child might be fine at delivery. And it might be a full term. But we're doing studies now. What do we see down the road? And they're beginning to see things like autism spectrums, ADHD, behavior problems, and things like that is what we're seeing. And Miranda is smiling.
I'm smiling because my mom smoked during pregnancy. I actually have autism. I have Asperger's. So
Yeah. Oh, yeah. Yeah. Okay. Let's see here. We have just a few more minutes. What do you want to do? Do you want to look at some more slides or ask me questions? You want to do NCLEX questions? What do you want to do? I can let you out a few minutes early today, but we do need to spend some little bit more time together. Is
You
there
have-
anything?
Do you have any cahoots?
Do I have any what?
Cahoots.
No, I don't have any cahoots. No. Do you?
I have that cup.
Who has backup?
No, I said I have that cup that you're drinking from.
Oh, you do? Where did you get yours?
I got it from Dollar General.
That's where I got mine. Well, you could get some good. I love to go there. I haven't been there in a long time, but I've got a really, I want to say nice one by me because it has so much stuff, but the aisles are so crowded. You know, they overstock them. They always send in. So the aisles you can hardly get through, but they have everything there.
Yeah, they do.
Okay. All right. What else? Let's see here. What else do I have? Haven't talked too much about the newborn. Chorioamnionitis. What happened? What causes chorioamnionitis?
Does that happen from the premature rupture of membrane?
I don't think I understood you.
Like the prom, does it happen because her water breaks too soon?
It could be. If her water broke and she's not in labor, it's called premature rupture of the membranes. Yes. So if she's not at the hospital, her water broke, but she's not in labor, and she doesn't come to the hospital, then she's at increased risk for bacteria traveling up the vagina into the uterus. So what kinds of clinical findings would you see if your client was developing chorioamnionitis? What would you see? What would you see if she had choreo? What would your findings be? Ah,
Maternal
tell me
fever.
you know. Huh?
Maternal fever.
All right. Fever, maternal.
Tachycardia.
Maternal AFP.
What else?
Foul smelling.
Okay, foul smelling. Amniotic fluid. Mhm.
One more. Maternal and fetal tachycardia, so both will have.
Can you think of one more?
Should her uterus be tender?
Uterine tenderness.
Okay. So what are you going to do? What do we need to do?
Penicillin, any kind of antibiotics.
What if she's allergic to penicillin? You don't have to know this. Do you know what we use?
Isn't it AMSA?
It could be. But sometimes people that take penicillin are kind of sensitive to ANSEF too. So we can use clindamycin.
And then she needs a C-section, right?
Not necessarily. But we do need her to deliver. So she's going to get antibiotics.
C-section at clinical, and when they were taking the baby out and suctioning up the amniotic fluid, the baby definitely had a bowel movement in the womb. You could see like the green color and the chunks of black mixed in with it. It was interesting.
So what causes intrauterine meconium release?
Fetal distress.
Stress on the fetus.
So hypoxia. You know, hypoxia, low oxygen levels in that baby's blood causes a vagal stimulation, which causes release of stool. Yeah. So there's two things going on with that fetus. So what kind of things what kinds of things would you see in the fetus if the chorioamnionitis affected the fetus? What are some outcomes we see with the fetus?
Vomiting and grunting.
So respiratory problems with the meconium aspiration, yeah. What about the infection? Well, pneumonia.
Pneumonia.
Yeah, pneumonia and meningitis. Okay. All right, now we have a newborn, a preterm baby. Okay, so if we have a client that comes into preterm labor, and let's say she is 32 weeks pregnant, she's in labor, and 99% of the time we can stall labor, or we can stall labor and birth, but it's inevitable. Okay, so as long as we can install it, the better off the baby will be if the membranes are intact and there's no sign of infection. Okay, so we have a client 32 weeks, she comes in and she's in labor. Okay, so we need to think of four things if we're trying to stop the labor. But if we're not able to, there's 3 things we need to do. We need to promote lung maturity. So we're going to give mother some betamethasone, a steroid, okay, to increase surfactant production by her lungs. We need to administer an antibiotic because most of the time preterm labor is caused by an infection, okay? And we need to administer magnesium sulfate. Now, why in the world are we giving magnesium sulfate? She didn't have preeclampsia. Why are we giving it? No, Miranda, don't answer. Why are we giving magnesium sulfate to preterm labor? I know that you're going to need to know this for the HESI about management, expectant management for preterm babies or labor. So why are we giving magnesium? Do you remember what it does?
Yes.
Is it for seizures?
Okay, it's for seizures, but why does it help a fetus?
Well, it's a CNS depressant, so it's going to stop contractions and then it's going to calm the baby and the fetus. I think.
Well, we don't give it to stop the contractions. Okay, so it helps the baby in what way? Do you remember? What did we talk about when mother was receiving it for preeclampsia? What's it doing up in the central nervous system? What's magnesium doing for the mother in preeclampsia? I know it's reducing the irritability. How is it doing that? Does anybody want to guess? Give it a try. It's protecting the baby's brain. How is it protecting the brain?
Is it something to do with the circulation with the placenta and stuff?
It's has to do with improving the blood flow of the fetal brain. Okay, improves the blood flow. It relaxes the cerebral blood vessels. It makes them dilate a little bit so that there's really good blood flow to that fetal brain. And it helps prevent cerebral palsy. Okay. When we give it to the mother with preeclampsia, it's doing the same thing. It's increasing the blood flow to prevent seizures. Okay. Oftentimes preterms will have seizures. If we give magnesium sulfate, it helps protect that brain during labor and delivery. What else might we see after magnesium infusion in mother during the postpartum period? What else does magnesium do? You could probably list 20 things that it does in the fetus and the mother. What else does it do? Postpartum, what are we concerned about with magnesium during preeclampsia? So somebody mentioned earlier that it helps relax the uterus, right? It sometimes can slow labor down a little bit. Her efforts at pushing might be hindered a little. So if she's not contracting as forcefully, what might you expect during the postpartum period?
Hemorrhage.
Prolonged bleeding.
More, yeah, bleeding. Yeah, so she's more at risk for postpartum hemorrhage. Yeah, good. All right, so we need to do these things. We need to try to suppress labor, slow it down and stop it. If we can give tocolytics, if we try terbutaline, it's not really used that often, to relax the uterus. Nifedipine helps relax. It's a calcium channel blocker, so it might relax the uterus. And some indomethacin is an anti-inflammatory type medication that can help the uterus relax. And it might slow down and stop labor, okay? But eventually it's going to happen, okay? So we're going to start her on some antibiotics and magnesium and give mom, if she's between 28 and 34 weeks, right in there, we can give her steroids, but after 34 weeks, it's useless. In fact, it might be more detrimental to give steroids after 34 weeks. Because remember that little area that blocks off the lungs, that ductus arteriosus? If we give steroids or nifedipine, or NSAIDs, that might close prematurely, okay? And we're not ready for it to close. All right, let's see. Labor induction, shoulder dystocia, we've talked about. Uterine rupture, let's see, I'm just going through this. Anaphylactoid syndrome, remember what that is? It's like pulmonary embolus, anything that's in the blood that shouldn't be there. So amniotic fluid, a bubble, can actually block the pulmonary artery and cause pulmonary collapse. And it's a code syndrome. I've never seen it. Deep vein thrombosis on the left. That left leg is larger. So as a nurse, signs and symptoms of DVT are an enlarged area, and it's usually warm, okay? We do not do the Homan sign anymore. We used to do it by bending the knees and pushing on the foot. It doesn't hurt. We don't do that anymore because we could actually dislodge the clot. Okay. But a venous a more superficial, like a saphenous vein, or not a saphenous vein, but a more superficial vein, it's not as much of a concern. Okay. But the deep veins, so we need to assess and measure that leg. What drug do we give to these women? If they have a DVT, what drug is prescribed? Anybody know? What anticoagulant is prescribed?
Heparin?
Heparin, yeah. So we're going to start her on some heparin, and she's going to be on bed rest. And when we see that leg beginning to reduce in redness, in size, then we know it's working. Okay, we don't want that clot to grow anymore. We want the body to reabsorb it. Okay, so we use heparin, and she'll probably go home on maybe Lovenox, or maybe even Coumadin. It just depends. Okay, and then there's a picture here of ITP. Okay, it's listed as idiopathic, but actually it's immune thrombocytopenia purpura. So the purpura is the massive petechiae and the spread of bleeding blood vessels. Okay, so this is low platelets. So any kind of liver disease, you might see this. Okay, so thrombocytopenia is low platelets. Some people have this as a chronic disease, and some develop it acutely during pregnancy. So you're going to see low platelets. So like less than, in this situation, hers is probably 30,000 or less platelets. How do we treat this? Anybody remember? Of course, it depends how low the platelets are. How do we treat it? It's an immune system problem. So we're going to treat it. If a woman has ITP during pregnancy and her platelets drop down below 50,000, and it's going to be different for every client, we might put her on a low dose, what? Steroid. Okay, steroid, like prednisone, low dose prednisone, so that that immune system won't cause those platelets to drop off completely. Okay, and then we might have to give her platelets during the postpartum period. Postpartum infections. Okay, so indication or a sign of a postpartum infection is a fever. And so usually after a few days, at least after the first 24 hours, maybe even when she goes home, if she develops a temperature at 100.4 or greater for 2 days in a row, we're making assumptions she has an infection somewhere. It could be endometritis. It could be mastitis. It could be a urinary tract, or it could be a wound infection. Okay. So that's what we call purpureal infection. Apgar. You just have to memorize it. So 7 or more is normal. 4 to 6 is low, moderately distressed. And then if it's less than 3 or 3, severely depressed.
I do have a question. Is the HESI going to ask us about the other chart thing that we score the babies on? The one that was in no, it was something else. I had to Google it because we weren't even taught that one, and they asked me to score a baby using it. in one of the next gen quizzes that I did.
Are you talking about gestational age?
No, it's about the baby's breathing. It's like a Stevens something.
Oh,
even know.
yeah, we don't even talk about it in this class. Probably
I know,
not.
and that's why I was like, I haven't even learned this. I had to Google it. But are they
Yeah.
gonna ask us that in the HESI?
Probably not.
Okay,
Probably
because
not.
that was the weirdest question. That was
I've never
that
heard a
was a hard
student
one.
say anything to me. Yeah. Yeah.
Okay.
So what's a sign of hypothermia? It's an early sign of hypothermia.
Cool skin.
Hmm?
Skin will be cold, shaky, shivering.
Hypoglycemia is another one.
Newborns can't shiver, right? Like not for the first 24 hours.
Yes.
Isn't that right?
Right. They don't shiver and they don't sweat. So that's why they can't regulate their own temperature. If they're hot, they can't do anything about it. They can't sweat. And that's why they're so dependent upon us. Okay. So signs of cold stress, cool, mottling skin, cyanosis, decreased responsiveness, jittery, tachypnea. Okay. All right. Know the modes of heat loss. Okay. How do we know that the baby, what's the signs of respiratory distress? This is easy. How do you know your baby's having trouble with respiratory distress?
Grunting.
Grunting, nasal flaring.
Grunting,
Intercostal retractions, subcostal
retractions.
retractions.
Mhm.
Retractions.
Head
Mhm.
bobbing.
Nasal
What?
flaring.
Seesaw respirations.
Seesaw respiration or paradoxical respirations. Yeah. Nasal flaring. They tend to be hypotonic. Their muscles are more relaxed because all their work is going into their breathing. Okay. And what is acrocyanosis?
That's a normal. Some extremities will be blue.
Okay. And that
And
has to do with circulation, right?
no, it's a normal.
Okay. Okay. Let's see. And then we have vitamin K. We need to give vitamin K because our babies don't have vitamin K. They don't have any bacteria to make vitamin K to give to the liver. What does the liver make with vitamin K? What does the liver synthesize?
Clotting factors.
Clotting factors like prothrombin in particular, okay? Prothrombin. So the liver is immature, as you all know, in a newborn. And so it has trouble with a lot of things, okay? And one is conjugating the bilirubin. So bilirubin is a product of the breakdown of red blood cells, hemolysis, okay? And babies are born because we delay cord clamping. They tend to have a lot more red blood cells than what they really need. And so those blood cells are breaking down. So some normal physiological jaundice is expected a few days after delivery, okay? So the liver has to conjugate in order to expose of the bilirubin. If bilirubin levels continue to climb in the circulatory system and spread throughout the tissues, then we have hyperbilirubinemia, okay? So we need to feed, okay? We need peristalsis to occur. And then there's other things we can do, Billy lights, Billy blankets, ultraviolet light, okay? So what's the difference between pathologic and physiologic jaundice? Oops.
Pathologic has an underlying cause. Physiologic is normal in the newborn after so many hours of life.
So pathologic, the underlying problem is what usually?
I believe it's hemolysis. I'm in an elevator, so if I have bad service, sorry.
So ABO or RH incompatibility. Okay. If the blood that baby has is incompatible with mother, there's hemolysis that occurs. Okay. And that hemolysis increases bilirubin levels. So if this occurs within 24 hours after birth, it's considered pathologic, and it's usually ABO. So if jaundice is occurring within 24 hours after delivery, it's considered pathologic. Okay. Physiologic occurs 3 or 4 days after delivery. Okay. And it's related to inadequate breastfeeding or just not enough feeding. Okay. So if the levels of bilirubin get too high, it's called kernicterus. All right. This is the ABO stuff. Retinopathy of prematurity, we're just about done here. And necrotizing enterocolitis. I don't think I shared this slide set with you. I guess I could send it to you. I'll send it to you. All right. Lots of stuff. Yeah. Passion says, yeah. All right, everybody. Thank you so much for your patience. And I hope